Thank you for joining us. We are now going to start today's webinar, Research on Women's Health in Primary Care. Before we begin, I'd like to go over a few details for today's webinar. To ensure audio quality for all attendees, we have muted everyone's lines. That means you can hear us, but we cannot hear you. Even though your lines are muted, we want to hear your questions. To ask a question, use the chat feature that is located on the right-hand side of your screen. You may have to click the arrow next to it to expand the section. We will answer questions at the end after all of the presentations are finished. I will now hand things over to Amy Eden to begin our webinar.
Thanks, Miriam. Good afternoon, or maybe morning, everyone. My name is Amy Eden. I'm the Acting Director of AHRQ's National Center for Excellence in Primary Care Research, or NCEPCR, and it's my pleasure to welcome you to today's webinar. Before we get rolling, just wanted to say a few words. Next slide. So a NCEPCR report released just a few months ago documented AHRQ's investments in primary care research, focusing on primary care grants that were active in 2021 and 2022. And of the 124 grants, fewer than 10% were focused on women's health or reproductive health issues. We know what an important role primary care plays in providing comprehensive care to women across the lifespan, but a Commonwealth Fund report identified a series of major gaps and structural barriers that really inhibit the current primary healthcare system from meeting women's needs. Next slide. We know also that primary care research focusing on women's health issues can provide evidence to transform primary health care for women of all ages and at all stages of life. And the White House's Women's Health Research Initiative that was announced earlier this year has really increased attention to the historically disparate attention given to women's health. And AHRQ's NCEPCR is really committed to supporting research designed to improve the quality of women's primary health care. Next slide. So in that light, I just wanted to call attention quickly to a few of our primary care funding opportunities and a special emphasis notice, which welcome applications that focus on primary care's role in women's health issues across the lifespan. I encourage you all to check those out. Next slide. And of course, many of our sister agencies support work in women's primary health care. And I'd like to just take a second to highlight one of them, and that is the CDC's Hypertension in Pregnancy Change Package, which multiple clinical societies have contributed to, including the American Academy of Family Physicians, to give a primary care perspective to this. The Change Package offers a whole menu of evidence-informed ways for individuals to change care processes that are related to hypertension in pregnancy. The primary audience for this change package is outpatient clinicians who care for pregnant and postpartum women, and it contains a whole bunch of actionable tools and resources that can help implement changes. Next slide. Relatedly, the Million Hearts Hypertension in Pregnancy Action Forum provides an opportunity for clinical, public health, and also community-based partners to exchange best and promising practices, identify solutions to common obstacles, share resources related to improving hypertension management, both during and after pregnancy. So I encourage you to check that out. Next slide. So the goal of today's webinar, to switch gears here, is to highlight the important role of primary care and primary health. We have some really great presentations lined up with researchers addressing some pressing and important women's health issues that really demonstrate the important role of primary care in comprehensive and coordinated continuous care for women. The presentations illustrate how healthcare policies, innovations in digital health, and primary care teams can uniquely impact the accessibility and delivery of women's primary health care. Next slide. So with that, I'd love to introduce our moderator for today's webinar, Dr. Keisha Koa. She's the Director of AHRQ's Division of Priority Populations. Keisha will introduce each of our presenters, and then at the end, she'll facilitate a Q&A and discussion, which will happen after they're all finished, but please feel free to use the chat or Q&A to put your questions in as you think of them. Welcome, Keisha. I'll turn it over to you. Thanks.
Thank you, Amy, and I'm thrilled to be moderating today's session. We have, as Amy said, I'm the Director of the Division of Priority Populations at AHRQ, and we have three fantastic presenters for today's webinar. Next slide, please. So our presenters today are Erika Barth Cottrell from OCHIN, and her presentation is entitled Reproductive Care in the Safety Net, Women's Health After Affordable Care Act Implementation, or EVERYWOMAN. She'll be followed by Leslie Lenert at the Medical University of South Carolina, who will be presenting EHR-based screening and intervention for intimate partner violence. And finally, we'll have Adonis Hijaz from the University Hospital's Urology Institute, who will be presenting Empowering Women and Providers for Improved Care of Urinary Incontinence, or EMPOWER study. So we have three really interesting and different presentations. And I'm gonna just wanna remind and reiterate what Amy said, that we're going to have the Q&A session after all the presentations are complete, so please feel free to jot down your questions as they're coming up, but we're going to hold off until the Q&A session. But you can also, throughout the session, use the chat feature to enter your question, and we'll get through as many questions as we can at the end of the webinar. And so at this point, I'm going to turn it over to Dr. Cottrell for the first presentation, Reproductive Care and the Safety Net, Women's Health After Affordable Care Act Implementation. So welcome, Dr. Cottrell, and please take it from here.
Great. Thank you so much for that introduction. Again, my name is Erika Cottrell, and I am a senior investigator at OCHIN. OCHIN is a nonprofit healthcare innovation company that provides electronic health record and health information technology services to a growing national network of community health centers. And we have an active research department within OCHIN. If you could go to the next slide. Disclosures, I have no financial disclosures or conflicts of interest. I do want to acknowledge our funders. Thank you, AHRQ, for funding this research. It was an R01 award from 2017 to 2022. As I'll talk about in the present, was conducted with infrastructure that was built by PCORI and PCORNet through the Accelerating Data Value Across a National Community Health Center Network, or ADVANCE. And I'll talk a little bit more about that as we go forward. Next slide, please. And I always have to start these presentations with a shout out to our amazing team. This project would not have been possible without the contributions of each and every person on the screen, as well as more. We had investigators and team members from OCHIN, Oregon Health and Science University, Health Choice Network, and Fenway Health, who all made enormous contributions to this study. Next slide. So just as background and to orient us to what we're talking about today, you know, we all know, and there's lots of findings that suggest that evidence-based reproductive care reduces morbidity and mortality for women and their children, decreases health disparities, and has really lasting social and economic benefits. We also know that community health centers, including federally qualified health centers and similar organizations, they are critical for providing primary care services for patients, regardless of their ability to pay. And they are the largest system of primary care for the United States low-income, uninsured, and publicly insured patients. And they are also an important source of reproductive health care provision. So as I noted on the slide, nearly a quarter of people who receive care in CHCs are documented in the EHR as females of reproductive age. So this is really a community health centers are really a critical access point for reproductive care and primary care for people who are publicly insured, uninsured, or underinsured. You know, historically, the federal government has targeted programs and initiatives to provide reproductive health care to low-income women. And those efforts have included, extending Medicaid coverage during pregnancy and the postpartum period to millions of women who otherwise would not be eligible for public insurance. And then there's also the Title X National Family Planning Program, which funds contraception and other sexual and reproductive health services for low-income women and men. So, we know that, roughly 1/4 of community health centers have reported receiving some sort of Title X funding. What we wanted to look at specifically in this project is the Affordable Care Act, which really prioritize reproductive health care as an essential component of women's preventive services, and also expanded insurance coverage to millions of low-income Americans by providing states the opportunity to expand Medicaid coverage to adults with incomes at or below 138% of the federal poverty level. What makes this further interesting is that in 2012, the Supreme Court ruled that states were not required to expand Medicaid. And what this ended up doing is really creating a unique sort of natural experiment to assess the impact of both the ACA and Medicaid expansion on women's reproductive care. As of January 2016, which was during the study period in which we were conducting this, 31 states and DC had implemented Medicaid expansion and 19 had not. So we're really able to sort of compare the outcomes across both of those states. So with that, next slide, we seized upon this opportunity and were, funded by AHRQ to look at this. So the specific aims of our study were really to describe provision of women's reproductive health care before and after the implementation of the ACA and between Medicaid and expansion and non-expansion states. We proposed this to do this specifically within a large network of CHCs. I'll get to that in a minute. We also wanted to look at other individual clinic or state level factors that may be associated with provision of women's reproductive health care. And then we added a third qualitative aim where to make sure that we were understanding the perspectives of those involved. So namely, patients who receive care, reproductive care in community health centers, and the providers, staff, and leaders in those community health centers. Next slide. The setting for this, as I have mentioned earlier, we conducted this work within the Advanced Clinical Research Network. Advance is one of 8 PCORnet clinical research networks funded by PCORI. And the goal there is to bring together many different health systems into a common data model so that health systems with disparate electronic health records are brought together and that data is transformed into a common PCORnet common data model that enables faster, more accessible research across different health systems with different EHRs. So Advance is led by OCHIN, which again, I mentioned before is a network of community health centers. And we have partnered with Fenway Health, Health Choice Network, which is another large network of community health centers, Oregon Health and Science University, and we recently added University of Washington as a partner as well. For this study, we partnered specifically with OCHIN, Fenway Health, and Health Choice Network because of the focus on community health centers. Something that distinguishes Advance from other networks within PCORnet is that we are the only safety net-led community clinical research network and have really built the nation's most comprehensive research-ready data on healthcare and outcomes among people served in community health center settings. This includes electronic health record data in the PCORnet common data model, and this is also linked to geocoded area level data on social determinants of health. And I think something notable, you can see on the screen sort of the patient distribution by site, the numbers, the vast numbers of health centers that are included across many states, but among the patients included, 56% are female, 53% are under the federal poverty line, 38% are on Medicaid, and 27% are uninsured. Next slide. So how did we do this? I'll give I'm not going to go into this in super depth, but I wanted to give a brief overview of sort of the methods we use for this. At the bottom, you can see there's a citation to our protocol paper if you want to get more information. But in the data that we used for both AIMS 1 and 2 came from our advanced data warehouse. The broad study sample were patients aged 50 to 44 who are listed as female on their medical chart with at least one office visit between 2012 and 2019, so that we were able to get the pre-post, and these there were 24 states included in this sample, and they were divided pretty evenly between expansion and non-expansion states. So this sort of base sample was around 650,000 patients. For each of the analysis we did, we may have had a smaller subset based on additional inclusion or exclusion criteria. The primary outcomes we looked at were preventive care, contraceptive care, and pregnancy care. And I'll go through some findings on each of those. If you go to the next slide. Yeah, next, there we go. So first, looking at, and for this presentation, I'm going to focus primarily on the impact of Medicaid expansion in the Affordable Care Act, so that AIM-1. We looked at trying to understand first preventive services. So we assessed the prevalence of receipt of 6 preventive services recommended by the U.S. Preventive Services Force. You can see those listed here on the screen. We wanted to look at change in receipt of preventive services within and between expansion groups. We used a difference in differences approach, which compared prevalence and screening before the ACA implementation in expansion states and then in non-expansion states. The pre-ACA timeframe was 2012, 2013, and post was 2014, 15. So you can see here on the slide, the blue bars are looking at Medicaid expansion states, and the orange bars are looking at non-expansion states. And just to cut to the chase, we had hypothesized that there would be more differences than we actually did see. So contrary to our hypothesis, there was really minimal difference between Medicaid expansion and non-expansion states. We did see increases post ACA. There were significant increases in across all preventive services in the delivery of those, but there was very little difference between expansion and non-expansion states. We're not sure why. It could be that patients in non-expansion states got insurance from the ACA marketplace, which would cover preventive care, or maybe patients with new access to Medicaid may have used healthcare differently. But we saw an overall improvement in the use, but not differences between expansion and non-expansion. And one thing to note is that despite the overall improvements post-ACA, the receipt of preventive services does remain low and really highlights the need for additional support of the CHC system to improve preventive service delivery to women and girls. You can see there's a citation there if you want to look more into that analysis. And next slide. Another thing we looked at is contraceptive care. Here we did a similar difference in differences approach. The outcomes here is we wanted to look at women who were at risk of pregnancy who received either a moderately effective or most effective method, which are hormonal and long-lasting reversible contraception. And then we also really specifically wanted to look at those who really received the most effective method, which would be long-acting reversible contraception, implants, IUD, talk about that informally as LARC. So we compared pre-expansion year to 2 time points, one immediately post-expansion in 2014 and a point longer after expansion in 2016. And again, we used a difference in difference model. In essence, to cut to the chase again, what we found is that Medicaid expansion under the ACA was associated with an increase in the use of the most effective contraception, meaning LARC, intrauterine devices and implants. So you see over on the right-hand side that graph, and you see the sort of the top line, which was expansion states, and we were able to see that increase. This is not shown on the slide, but it is important to note that the increase in contraceptive use was larger among a uniquely vulnerable populations, adolescents who seek care in CHCs. And then another interesting point is you can see here we distinguish between women who had a Title X visit in an who visited a clinic that was receiving Title X funds. So one caveat to this is we were still able to see, you know, the ACA had a big impact, but we're still able to see the impact of Title X as well. So women who had a Title X clinic visit in regardless of expansion or non-expansion states had a higher level of receiving any contraception. And the citation at the bottom, you can see for more on this one. And then the last, I'll have to get moving here. I'm taking a little bit too much time, but if we go to the next slide, we also wanted to look at prenatal care and CHCs. I bring this up here to show you that community health centers really are an important source of prenatal and pregnancy care. It is tricky to identify pregnancies in the electronic health record. Our analysts spend a lot of time figuring out how to define this, and actually it worked really hard to even be able to identify this statistic that we put here on the left, that 41% of health centers in the Advanced Clinical Research Network provide longitudinal prenatal care. This is a really important thing for us to know. We also saw that patients who received longitudinal prenatal care were racially and ethnically diverse, and many had comorbidities. The next slide. We also wanted to look at how Medicaid expansion changed insurance covered in the perinatal period. As I mentioned before, you know, policies enable women to gain Medicaid during during pregnancy. And we examined the association between perinatal insurance coverage in expansion and non-expansion states and receipt of postpartum care and contraception. And in short, women in expansion states were significantly more likely to retain Medicaid coverage postpartum. We also saw that women losing Medicaid coverage after childbirth were less likely than privately insured women to receive the most effective methods of contraception. So again, demonstrating the role of insurance on influencing receipt of postpartum care and contraception. And just briefly, I'll go through some of the qualitative methods. If you go to the next slide, for our qualitative aim, we recruited 6 community health centers, 4 from expansion states and 2 non-expansion states. We conducted 30 interviews with women of reproductive age who had had a live birth in the past 2 years, and another 30 with staff, clinical, and health system leaders. We really wanted to understand their perceptions of the policy impacts on reproductive health care and experiences accessing and delivering care in CHCs. And on the next slide, you can see some from our patient interviews. We really did see that patients expected their primary care to include reproductive care. They wanted their complex histories, experiences, and need acknowledged. They identified community health centers as an important source of care, and really also connection to other community services that enable them to maintain their health. So that was it was interesting to see that sort of alignment there. And the next slide, we have just a few thoughts on the perceptions of providers, staff, and leaders who really affirmed that ACA and Medicaid expansion broadened access to preventive and contraceptive care. They doubled down on the availability of services in uncertain practice and policy environments as being persistent barriers, and really identified CHC funding and functions and integrated services as important for reproductive care access and delivery. And next slide, or last slide, I just wanted to kind of highlight overall what we learned, and I think there's a few key points. I think we really were able to demonstrate that EHR data from OCHIN and Advance, one of the PCOR clinical research networks, it's really a uniquely valuable tool to understand the immediate impacts of assessment of policy impacts and to enable sort of a broader consideration of that. We are able to capture women who both have insurance and don't have insurance, so that we're able to see people as they cycle on and off insurance. If you use a more typical claims data set, you won't be able to see that. We saw preventive care provision increased after ACA implementation. Provision of most effective methods of contraception was higher in Medicaid expansion states, and Medicaid coverage postpartum postpartum was higher in Medicaid expansion states, and we saw that Title X continues to play a vital role in contraceptive access for CHC populations. And again, I think through the qualitative, it really highlighted again the essential role that community health centers play in providing reproductive care, and that policies that expand access to healthcare coverage are really critical for reproductive health equity. And with that, I will say thank you. And on the last slide is contact information and our website if you want to look at anything more, or I think I took that out. Thank you so much.
Thank you, Dr. Cottrell. Next slide, please. And I'm going to turn it over to Dr. Lenert from the Medical University of South Carolina, who is going to introduce himself in a little bit more detail and then give his presentation on EHR-based screening and intervention for intimate partner violence. Dr. Lenert.
Hi, my name is Leslie Lenert. I'm the Associate Provost for Data Science and Informatics at Medical University of South Carolina and primary care provider. I'm pleased to give this presentation on the work I've conducted with my colleague, Alyssa Reingold, funded by AHRQ through R18, HS 025654. Next slide. So the problem we're addressing is how best to care for intimate partner violence. It's an unfortunately common problem. About 6% of women face an episode of intimate partner violence per year who are of childbearing age. And the lifetime prevalence is around 20%, but could even be higher in some populations. The issue of whether intimate partner violence is a primary care problem is debated at a national and international level. The U.S. Preventative Services Task Force argues, yes, universal screening is recommended. Screening does unequivocally increase the rate of identification of patients at risk for intimate partner violence. The World Health Organization argues that universal screening, while it identifies more patients at risk, it doesn't necessarily improve different rates of other outcomes. And so it recommends that screening be driven by clinical suspicion, that providers have the capacity to be able to intervene in these areas, but not to do universal screening. There's been a number of successes or failures in primary care environments, mostly successes. It is well established that intimate partner violence screening does detect more cases. One of the model programs for this is the Kaiser Permanente program, which demonstrated again that you're really able to impact this in a primary care environment as you go forward. Next slide. So our task in this grant was to automate the best practices for IPV screening in electronic health record system-based platform. It was modeled on the Kaiser Permanente program. It was attempting to be comprehensive. It would screen the patients, assess their risk, refer them in clinic for a warm hand follow-off, work to integrate the program with community resources, and in general, attempt to make primary care a home for caring for patients at risk for these problems. We wanted to be able to demonstrate to patients the ability to preserve their privacy during screening. For us, one of the biggest barriers to being able to do effective care for patients at IPV was to be able to protect the privacy of these patients from the perpetrators of violence. So we developed a protocol for highly confidential screening in the clinic, and we'll go through that using the electronic record system. We also added tools to be able to segment data in the electronic record systems to prevent accidental disclosure through billing, after-visit summaries, or release of medical records. After developing these approaches, we compared their effectiveness to usual care in a cluster randomized trial. Next slide. Our approach was population-based. We wanted to look at all the women who were in a targeted age range across all our clinics. We used a user-oriented design approach, working with clinicians iteratively to develop feedback for the intervention and different approaches for using EHR templates for care. We integrated the screening tools with risk management tools and referral to a national hotline in a single EHR-based workflow. And then we use best practice alerts for workflow management and access to the data on return visits, as opposed to having identified notes or other things that might disclose the activities. Next slide. So this was our control condition. This is a routine checklist that our providers complete for screening for intimate partner violence and other aspects of domestic violence. That the checklist items are shown on the left. When one clicks on one of those, you can indicate a qualitative issue with one of these things, areas here for subsequent tracking and follow-up. The screening was done by medical assistants during the initial rooming process for patients. Next slide. So it sort of shows our population-based process where we had a registry of all patients. We would again be tracking whether they had a positive screen or a negative screen in the registry. If someone had a positive screen, we would continue to administer the screen until the situation was resolved. If they were negative, we of course returned them to the registry and brought them back to the to a normal state, and we would review this again after a year or so. The point, though, is the screening process was the entryway into a physician assessment where the physician would determine the risk to the patient and then undergo a referral to a hotline so that the patient could potentially get help on the spot through a warm handoff. Next slide. So this is the intervention state. What you see on the left-hand side is a non-interruptive alert that shows that the patient was due for or needed to have an intimate partner violence screening battery. Patients who had this, when you clicked on it, this converted the exam room computer to a kiosk mode. The kiosk mode displayed a questionnaire, the first questionnaire there, which screened patients with 3 items. If any of the items were positive, we moved on to a danger 5 risk assessment, which was shown in the second screen. And then the third really asked about whether a patient felt they were in immediate danger and we needed to institute some kind of protective protocols for that patient in the clinic. So going over the whole parts, you can see that the intervention has both a reminder that's there for that's on the screen continuously when you need it, plus this idea of being able to use the exam room computers to administer questionnaires for direct confidentially to patients. Now, when we use this in clinic, we develop a protocol where the patient was left alone in the room. Other members of their family were taken out briefly, particularly male members or other people who are accompanying the patient, and that they were able to complete this questionnaire privately. And then when they completed it, the exam room computer was locked, and then it was waiting for the patient's care provider to be able to complete their examination of the patient and their recording of patient care. Next slide. When there was a positive alert, this hard stop best practice alert was triggered within the electronic record, showing that there was at least one risk factor for IPV and reporting on the Danger 5 assessment available for patients. Clicking on this alert, and next slide, took the provider to a form where they would be able to assess the risk to the patient, review the data, conduct a physical exam, determine if a minor had been exposed to the violence, which was would have triggered mandatory reporting to Child Protective Services, and or refer the patient to the national IPV hotline using a 1-800 number where we would give them a secure phone and allow them to contact that in the clinic. Next slide. sort of shows the additional parts of this where you could record the note, do an assessment. We allowed the provider to decide whether they wanted to make a diagnosis of IPV that would be protected and kept in that confidential area, and then to record the amount of time used in the visit so that they could potentially be compensated in terms of RVUs without billing. Next slide. So a major part of this process was designing additions to an electronic medical record system that could segment the data. We were concerned about disclosures to patients' feelings about risk of IPV or other things to the perpetrator. And this could occur on the patient's phone if we send it to them. There could be software monitoring that, or if we allow this to happen in the patient portal, that there was no way to guarantee that the perpetrator might not have access to this data. We're also concerned about after-visit summaries, the required paper documents that patients are sent home with based on federal regulations. Insurance billing was another way that patients could have an IPV diagnosis disclosed as part of the supplemental evidence for billing. And then medical record release was another area where we were concerned about this. So in segmenting the data, what we did was we stored the IPV questionnaire results separately from routine parts of the medical record. The physician assessment, diagnosis, and treatment plans were also stored in a separate secure area. The time and the visit complexity assessment was also stored without billing, and that the problem list of the patient did not include IPV diagnoses or counseling. This data was accessed on subsequent visits using a best practice alert that notified the provider that the patient had data that wasn't recorded in the main medical record. Next slide. As part of rollout and implementation, we tested the workflow and templates with providers with simulated patients going through the actual interviews. We trained the providers with online tools and presentations using remote learning methods. We conducted in-services for clinic staff in rooming procedures and in the goals of the study. We supported clinics during the rollout dates for the intervention by having staff on site. And during implementation, we had routine meetings with clinic managers to review the compliance data, address issues with implementation, and adapt the software if needed. Next slide. We evaluated our tools in a cluster randomized trial where we stratified 15 clinics by their racial and ethnic composition and size into three groups, and then rolled out the intervention across the groups. Group membership was determined at random, typical for the cluster randomized design. So what you can see here is that there was a baseline control period, there was an intervention period for the first set of clinics, and the second set was added, and then the third step, in a third step, the last 5 clinics were added. This design allows each clinic to be a to be a control for itself, as well as provides contemporaneous controls for trends in healthcare utilization. Next slide. This is the results from our study as described in our paper in JAMA Open, that the mean age of patients in our population was about 35 years. 26,000 patients were in the clinics that were being seen. Of the patients that were being seen, about 8,900 were seen during the active intervention period. The control periods, about 17,000 patients were seen in those clinics during that period. The primary outcome of the study was the rate at which IPV screening occurred, and then we also looked at the ability to go on and manage patients after that. Our findings are fairly impressive, that the overall approach of training people and integrating IPV in care raises the rate of screening on average from 40% to 65%. And that that was true for screening regardless of the method that was done. So either using the MA-based form or the clinic private questionnaires that we had created. However, looking at the second bar graph, you can see the issues that occurred with other methods for screening. If we did not use the highly private approach for screening, the detection rate was very low. Only about 10 people were identified using this approach, whereas about 120 people or so were identified using the highly private approach, showing that it was about 10 times more effective in identification of patients at risk. So again, an approach where self-reported questionnaires delivered in private to patients, where they could answer these questions without other people in the room, was much more effective than just asking people or trying to look for signs of that with an interview by medical assistants. All right, next slide, please. So I think one of the things that was most concerning about this study was that of the patients who screened positive, about half of those patients would be at very high risk, as based on the Danger 5 assessment. So you can see here the Danger 5 is a kind of questionnaire that asks, has your partner or anyone else been violently and constantly jealous of you? Have they ever tried to choke you or strangle you? These are not routine events in life, but what you can see in the risk score here is that many of the patients identified by this approach were at serious risk of injury based on the Danger 5. Next slide. Now, looking at other aspects of the care of this, that it's unfortunate, but I think that a minority of the clinicians went through and used the best practice alert to access data from the patient's interview. It's about 50% actually, so that there were some serious issues that they missed as a part of this. But you can see there was often recording of counseling of the visit. There was about 11 cases where the IPV was diagnosed. But there was a lot of missing data in the situation as providers went ahead with routine care rather than addressing IPV as an issue. We had 4 patients who used the hotline in a warm handoff to obtain care on the spot, which is interesting and leads us to believe that this may be an area where we need to pay attention to intervening with patients over time to get them ready to act. Next slide. The reported time for counseling for these patients was relatively low. In most cases, it was less than 15 minutes. There was a few cases where more time was required because these were fairly serious events. Next slide. Compliance in our clinics was highly variable. Some clinics were very compliant with the approach for implementation of this, and some clinics were not compliant at all, or very intermittently compliant at best. And that this shows that we needed to do a lot more work with engagement of clinic staff and with development of approaches that incentivize the clinics for interrupting their workflow to do highly private screening. Next slide. Okay, so to summarize, a highly private approach to screening is much more effective at identifying patients at risk. More screening takes place when we used our EHR-based approach and reminded people to do this and created this environment, but we really only found more cases when the highly private kiosk-based mode for screening was used. The risk levels in patients identified through this were very high and disturbingly high. So even so, we found that clinicians often ignored the best practice alerts to look at the data. This will require more strategies on how to intervene with clinicians to get them to take this seriously. The intervention is a bit difficult and may require ongoing management in clinical settings, and that clinic compliance was an issue that we observed, and that we need better strategies to address this. But overall, what we can see is that the approach is very effective at identifying patients and provides a strong environment for managing intimate partner violence in primary care. This does call attention, though, particularly to the need to do implementation science research in primary care settings to best understand how to address confidential issues like this. The work on the informatics side with the protection of the data so that patients can feel free to disclose it is also important, and that most electronic health record systems do not support this directly, and that additional engineering of these commercial systems needs to be done to make this happen. Thank you very much. I think that's all I have to present today.
Thank you, Dr. Lenert. And finally, our last presenter, Dr. Hijaz, will be presenting Empowering Women and Providers for Improved Care of Urinary Incontinence Empower Studies. I will turn things over to Dr. Hijaz to introduce himself a little further and give his presentation.
Thank you. I would like to thank National Center for Excellence in Primary Care Research. My name is Adonis Hijaz. I'm a practicing urologist. I'm also the vice chair of the Department of Urology at University Hospital in Cleveland. Next chart, please. So in addition to that, I'm the co-PI on this Empower study, the U18 funding mechanism through AHRQ. So we'll talk about the MUI, the Management of Urinary Incontinence Initiative that AHRQ initiated. It has funded at least 5 centers across the nation, and our center at University Hospital is one of these centers that were funded through AHRQ. And the MUI initiative aims to implement patient-centered outcome research on effective non-surgical treatment of urinary incontinence in the primary care practices. So why is this significant? We know about the prevalence of urinary incontinence. Urinary incontinence in women is highly prevalent. More than 50% of women over the age of 20 experience some sort of urinary incontinence. Importantly, around 30% of women older than about 30% of older women in the United States have moderate to severe urinary incontinence that affect their physical, psychological, and social well-being. Despite the high prevalence, we have noticed that there are fewer number of patients seek care, and there is a big gap. In addition to that, PCORI has completed a systematic review that highlighted that non-surgical management of urinary incontinence, namely, we're talking about physical therapy and behavioral therapy, is effective in treatment of urinary incontinence. You have a condition that's prevalent, you have therapy that's effective, yet patients don't seek care. If you go to the next slide, please. So it's well known that around 2/3 of women who experience urinary incontinence have not spoken to their primary care physician or to the doctors about incontinence. And in addition to that, that leads to around 6.5 years of delay in seeking care. So on average, women wait at least 6.5 years to seek care and talk to professionals about incontinence management. And part of it is multifactorial, but part of it is the 40% of women report embarrassment as being the underlying cause for that. But obviously, there are multiple barriers at the level of the patient, at the level of the system, at the level of the primary care physicians, or even the physicians in general, that prevent that from happening. So the initiative that is supported by AHRQ, the MUI initiative, is to come up with ideas to engage the primary care practices to help us deliver this evidence-based effective therapy for women to improve women's health, specifically in the area domain of urinary incontinence. Next slide, please. So we at University Hospital in Cleveland, we put together a multidisciplinary team. We partnered with our colleagues in family medicine. My co-PI is the chair of the family medicine at University Hospital. We also partnered with the Primary Care Institute, which is an institute under which all the primary care practices within University Hospital reside. And we designed a multifaceted approach to achieve the aim of the MUI initiative. And the focus of our project is to empower through education, empower women and empower providers through education. And at the heart of this project is we attempted our best to minimize the burden on the primary care physicians and the practices and the staff in the primary care facilities, because we know that one of the major issues that prevent initiative as such of being successful is the perceived burden. So, and in that, we created this multifaceted approach, and that includes screening, patient education, provider education, utilization of nurse navigation, and a chatbot we call CC, that is an AI-delivered chatbot that will help navigate patient through the care pathway. And our goal, our aim from this project is to implement the project across the large network of primary care physicians and make sure that the implementation is done according to what we promised. In addition to that, as a byproduct, to create tools, one of the tools that we've created is the patient-centered care pathway that is utilized by the nurse navigators in our study, but also will be available for the providers to utilize to help them navigate patients through the care pathway and deliver care to women with incontinence. And in addition to that, we wanted to assess the impact of this program on outcomes that relates to patients that are part of the initiative, also the outcome as it relates to the provider knowledge on continence, their confidence, their workflow, and their satisfaction. Next slide. So in order to achieve the goal, before we do go into the details of how we conducted the study, but we wanted to onboard a number of primary care physician practices. Under University Hospital Primary Care Institute, there is a total of 105 practices. We were successful through our interaction with the PCI leadership, the regional leadership of the practices, the medical directors of the practices, the office managers, the staff of the offices. We were successful in engaging a total of around 60 practices in this initiative because the participation in the initiative was voluntarily. And within each of these practices that we onboarded and aligned with the initiative, we identify practice-specific champions, and these could have been front desk officers, medical assistants, office managers, that allows us to participate and do the screening for the urinary incontinence. Because an element of this study is to hand out screening to our patients who walk through the offices. And a third aspect is to engage providers from each of these practices, at least one or two, to participate in the master class, which is utilizing an echo platform to educate them about the management of urinary incontinence. And finally, with the women who screen positive utilizing the screening, we invite these women to participate in the randomized clinical trial to test what would be the best approach to deliver this evidence-based intervention. So within the Northeast Ohio footprint of University Hospital Primary Care Institute, we divided those offices into 3 regions. And the Northwest and the Southwest region is one wave, the Central and the South region another, and the Northeast and the Southeast region as a 3rd wave. And we did the implementation in the 3 waves consecutively. And we started that by giving the primary care physicians, after engaging them, a 1-hour seminar on urinary incontinence together with their staff. This is followed by a masterclass series for the providers. This is 8-week CME course for the primary care provider to learn about the management of urinary incontinence. And then as we engaged the offices, we started handing out the screening questionnaires within the offices to any woman who walk into these offices over a period of 6 months, 18 and above. Next slide, please. This is a picture of the screening questionnaire. The screening questionnaire is called the ICIQ short form. It is a validated questionnaire that captures not only presence of incontinence, but also the degree of incontinence. And it's weighted, so the patients will have a score at the end when they complete the questionnaire. It's a 4-question questionnaire, not burdensome to complete. And once they complete the questionnaire, they can be either classified as slight, as moderate, severe, or very severe urinary incontinence. And in addition to the embedded in the questionnaire, we had an invitation to participate in the randomized clinical trial, which we will discuss soon. So we had 2 arms to the study. The first arm is the screening initiative and onboarding the offices and building capacity within the offices and trying to tackle what we call provider-related barriers. And the second arm, after we screen, and if patients screen positive, invite them to participate in the randomized clinical trial. Next slide, please. And in this randomized clinical trial, we randomized patients to one of 3 arms. And actually, the offices were the ones that are randomized into these 3 arms. Arm 1 was usual care. So some of the offices fell into that arm. And usual care, essentially everything we've done so far with education of physicians, some of the education material we give to patients. And then once the patients screen positive, they are encouraged to talk to their primary care physician about urinary incontinence if they desire. And the primary care physicians will manage the patients based on their knowledge, understanding, and willingness. In arm 2, patients who are randomized in arm 2, they are having usual care, but also a nurse navigator that guides them through the care pathway over a period of 8 weeks. And in arm 3, they receive this help of the nurse navigator as well as the artificial intelligence-driven chatbot called CC for a total of 8 weeks. And then we follow the patients closely, and at the end of 6 months, we report the primary outcome, which is the change in incontinence based on validated questionnaires and other questionnaires we have gathered. Next slide. This is a picture of the upstream of the clinical care pathway. This is the interactive pathway that we've created as a byproduct of this project. Allows the physicians as well as the caregiver to plug the patient into either having urinary incontinence with urge, or urinary incontinence with stress, or a mixed picture. But there is definitely subsequent downstream and detailed algorithmic described treatment options that will follow that the provider can follow. So that is a very helpful tool that our nurse navigators used throughout this project, but also we have kept this tool and developed this tool, and now to utilize it in our sustainability menu that we give back to the primary care physicians and their offices after exiting through the Empower. Next slide, please. So what we have done so far, as I have not said this so far, but we just finished the screening initiative. We also recruited for the randomized clinical trial. We are continuing now to follow the patients who are in the 3rd wave. So we have not yet finished the follow-up of these patients, and therefore the first 6 months data is not yet available for us on the follow-up. But this is what we have done so far. We screened a total of 15,167 women in the 3 waves. And when we looked at the screen data, we have seen that we have 58% or 56% of the patients had any urinary incontinence. 47% of patients had no incontinence. So this is consistent with what we started talking about, that the prevalence of urinary incontinence, at least at any level, is significantly high in our community. Next slide. And when you look at the severity of urinary incontinence, 51% of the patients who said yes, they screened positive for incontinence had only slight. But significant to this study is that a total of 47% had moderate to severe, and 2% had very severe urine incontinence. At this moment, what we're doing is we are going to look back at this screening data and actually capture some of the demographic variables for these patients that were screened. We have a study that we are initiating to look at that. We are looking at the bother that is associated with this reported prevalence. Next slide. So of those patients who screened positive urine incontinence, who were invited to participate in the randomized clinical trial, we were able to engage 400 patients that were randomly assigned to arm 1 or 2 or 3. And those patients who are engaged in the study, their average age was 57.8. As I said, their data, baseline data is all acquired, but we don't have the follow-up data. We haven't looked at the follow-up data yet because we're still gathering it. And by the hopefully end of the fall, we will have the data available for us, and we'll start gathering outcomes. What we have at least learned so far is from just a quick glimpse on the data is that the patients who were navigated, so who worked closely with the nurse navigation, were more adherent to the intervention. And then the patients who were utilizing the CC. So the adherence rate, meaning consistency with nurse navigation, was around 80%. The arm 3, the nurse navigators was around 80%. What with the chatbot was around 60% adherence. But still, as I said, we will be looking at outcomes data in the last half of this year. Next slide. If you look at the characteristics of these patients who were enrolled in the randomized clinical trial, contrary to what we saw in the screening data, here we see that the percentage of patients who had moderate incontinence and severe incontinence obviously was higher than the section of patients who had slight incontinence. And that's explanatory. I think patients who have the moderate and severe incontinence are more engaged to participate in studies than if they had only the slight urine incontinence. But it's not, what's really interesting is that even the patients that had slight urine incontinence participated in this study with us. And when we looked at the race of the enrolled participants, the 87% of these patients identified as white, 11% were Black and African American, and 3% identified as Hispanic and Latino. Next slide, please. So what were the lessons learned? I think for us, there were multiple levels of preparation that led to the actual implementation. We had a lot of work that we put at the front end, talking to institutional level leaders and practice level leaders in order to have their buy-in participating in the study. And once we got the buy-in, and once we were able to onboard an office or a practice, having people within the office, whether it is a front desk person or a medical assistant or an engaged provider, was extremely important for the success of the screening initiative. Because even in the office that onboarded, we've seen some offices did amazing in completing the screening, and some offices were having a few amounts of screening being turned in. So even if we guarantee the engagement at the system level, at the leadership level, and at the office leadership level, which is the office manager and the practice lead, implementing such a screening initiative really took a lot of engagement from people on the in the trenches, essentially, to help us. This study initiated while we were making a transition in the EMR system. So now we have an EM system which allows us to build in screening within the AMR, and this is one of the byproducts, hopefully, that we will that we are taking on now, is to incorporate the screening within the AMR and now come up with the approach to allow us to utilize it in the primary care setting. Another point that we were interested in learning is that although we were excited about the AI chatbot, patients really like the personalized interaction with the nurse navigator, and although we assume that maybe an AI chatbot will avoid the embarrassment to talking about the incontinence to another person, but that was not the case. Our nurse navigators did a great job connecting to our patients and help navigate the patient through the care pathway. So these are some of the learning lessons that we have gathered so far in our journey. We're very excited of this project and the potential that of what we have done and the learnings that we will get out of it. And any of this would not have been done without the amazing team that worked together on the conceptualization piece, but more importantly on the implementation piece. Our team that has diligently conducted the onboarding, the randomization, the nurse navigators, and the office staff for sure for being great partners. I think this concludes my presentation, and thank you for the opportunity.
Thank you, Dr. Hijaz. I just want to thank all three of our presenters. They gave really innovative talks on the work they're doing on a wide range of women's health topics using a wide range of methodology. So it's really interesting. I want to remind folks to please post your questions in the chat. We have about 5 or 6 minutes for questions. And while I'm waiting for audience members to enter their questions into the chat, I'll ask 1 or 2 questions myself, but we definitely want to hear from audience members. So the first question I have is, doing research in primary care settings can be challenging. And Dr. Hijaz, you were talking a lot about trying, really thinking about ways to minimize burden. And Dr. Lenert, you were even talking about some providers not sort of following the protocol as intended. So kind of a 2-part question is like, what are the biggest challenges in conducting research in this setting? And what are some solutions that are best practices that you found to help overcome them? I'll pause there and then ask the second part of my question afterwards, but that's to any or all of the presenters.
Say quickly too, I think I really want to hear from the other 2 folks, but as OCHIN is really as a network of community health centers, and we do want to minimize the burden on our clinics. They are incredibly stretched, especially community health centers. They're providing care to our most vulnerable patients in the US. One way we have tried to minimize burden is to do things like we did in the study here, where we're utilizing data that's available to look at things in a sort of a natural experiment type of way. There's a lot you can do with the data they collect in day-to-day healthcare without having to go into the clinics and have them do extra things. We also do lots of research, like the other 2 presenters today talked about it. And one of the things we try to do is make sure that we're prioritizing studies that address the needs that the clinics have. So, if we're coming in with something that really doesn't matter for them, it's going to be a lot harder and a lot more of a burden versus if it's something that they perceive that will help their clinical workflow or their quality metrics, et cetera, et cetera.
I think the biggest thing is to deal with the financing for the clinics, that the RVUs have to reflect the activities that are done both for patient interventions, but also for research. And so I think it's going to be important to figure out how we can supplement the funding of clinics specifically to allow physicians to have time for research and to participate in research projects. It's not going to be enough just to fund this off of care. There is no extra wiggle in the system anymore for people to be able to do extra activities, even when they probably perceive that they're very important. Now, when we build stuff, we really try to make it the right thing, the easy thing to do, and to reduce the burdens, as Erika said, that we don't want to make things any worse. But it's such a demanding environment. We need to be able to introduce actual trials like we did with, that are randomized or block randomized or other things like that. This does require extra time, and we need to figure out ways to enhance billing to allow that.
I do echo both comments. I think the biggest challenge is the time limitation that the providers and their staff have on their daily execution of what they do, taking care of our patients. So they're pretty time constrained, and to ask them to give their patient another screening and then act on that screening tool was one of the biggest hurdles. Like when we talk to our primary care physicians, like, can you give the screening out? So it's like, okay, now I have 10 minutes or 15 minutes to talk to my patients. Now, if she wants to come back and talk to me about urinary incontinence, I'll be limited with my time to answer that. So, yes, making sure that their activities are subsidized or having ample time to do that. But we're trying to come up with innovative ideas so that if they conduct the screening, whether it is in person or through the EMR, that we can generate EMR triggers that will connect them to our team outside, so that we can take care of the burden that they have.
And I had one more thing too, just building on both of those comments. I think that often we've had to even request to go over the cap on some budgets when we do involve our clinics. And so I think, as Dr. Lenert said, just the recognition that there is a need for reimbursement for these clinics to be able to participate in the research. And there is very little margin, and there's very little research infrastructure that exists. And so making sure our budgets can account for that is really essential.
So, for example, for us, just to go on it, we couldn't afford to do tablets in the clinics for collecting patient data. We had to figure out how to build that into the EHR using kiosk mode. Tablets would have been great, but there just wasn't funding for that necessarily. So that's part of the engineering that we do. I think in the future, you're going to see consent built into these processes. You're going to see randomization built in automatically. This will all take place behind the scenes as people go forward. But I still think that if a clinic is running these sorts of trials, that they probably deserve a little bit more funding for reimbursement for a visit than a clinic that's not doing it.
Thank you. And we have an audience question for Dr. Lenert. It says, is IPV screening only for women? If so, how are other relationships and gender screened?
No, we did this just with women for this targeted population to evaluate it, because we had a better idea as to what the background rates of impact were, and our ability to reach out to them. I agree with you that IPV screening is for both genders. It's just much less common in other situations. I think that in transgender people, it's particularly important that we do this. We just haven't addressed that specifically in this study. But I would be delighted to work on future studies that were aimed at prevention of violence in those populations, since it's even more common than at women at large.
Thank you. And I have several other questions where we're at time, and I want to be respectful of folks' time. So I just want to thank our three presenters today for giving really engaging talks and answering a few questions. I thank our audience members for staying with us for the time. And I just want to let everyone know that, there's going to be future webinars. We encourage you to participate in those. And once we close out of the webinar, there's going to be an evaluation poll. And please complete that, because that's really helpful for AHRQ in planning future work in this area. And just thanks again to everyone. And I hope you guys have a great rest of your day.
Thank you.